Fantastic. Good afternoon, everyone. Thank you for joining us today. My name is Jeff Schutz. I'll be moderating this episode of our NRBS sponsor series, focusing primarily on iMedisync, one of our sponsors. I'm on the board of directors with the NRBS and president-elect. Today's topic will be modernizing ADHD, AI phenotyping, and precision PBM care. For those of you that are not familiar with it, PBM stands for Photobiomodulation. We have the privilege of receiving this from Rebecca Walker. Rebecca is a sales and marketing specialist at iMedisync, but that's not all there is to her. Rebecca has her master's degree in applied psychophysiology from Saybrook University, and with her husband, she is a co-owner of Walker Therapy Services in Las Vegas, Nevada. She's actively involved with multiple leadership roles, including Brigham Young University School of Family Life Counsel and the Sassoon. I think I got that right. It's
Very good.
SUISUN, Sassoon Summit Planning Committee. And I'll come back around to some announcements later on, but I know we do want to emphasize and highlight.
Did Jeff get cut off?
Yes.
Okay. What was he going to highlight? I'll just go ahead and jump in and take over. Thanks for the introduction, Jeff. We actually have a location in Provo, Utah as well. And let's dive right in. I want to give notice that iMedisync is having a 3-day workshop coming up in Denver on June 12th to the 14th. And we'll be looking at EEG measurements, the raw EEG phenotypes. We took a survey, and the most requested topic was learning how to interpret the QEEG. So in response to that, our workshop will be reviewing multiple case studies to demonstrate real-world clinical application. So when you get back to your office, you can feel more confident on how to proceed. On the next slide, I want to mention that we are also starting our iSync sessions. They're just a free platform for us to get together and review other cases. Our first one will be April 8th at 4 p.m. Pacific. So we'll drop the registration in the chat box where you can sign up for either. It's imedisyncamericas.com, and then you go to the event page. All right, so if you go back one more slide. To start things off, I'm going to play a little audio clip that my husband wrote. So go ahead and press that right there. If I play it on my end, will it sound? Okay, well, I guess I'll have to do impromptu. The song is Where'd I Put My Adderall? Holy crap, holy crap, where did I put my Adderall? I don't know if I can make it through the day. If I don't have my Adderall, I think I'll go insane. So it was really cool. It had like sound effects and drums and everything way better than what I did. But this was written because every morning my husband would misplace his Adderall. And so he just naturally, with his beta brain, wrote this song. I'm sorry you didn't get the full effect of it. But we will review what phenotype that is for someone who needs their Adderall to function very well. All right, so on to the next slide for our learning objectives. We will review definition of ADD. We'll look at AI in the EEG and QEEG. We'll also look at the EEG phenotypes of ADD. We'll review some iMedisync AI reports as well as photobiomodulation, and we'll review some case studies with that. So on to the history of ADHD. Next slide. And then the slide after. All right, so ADHD was first titled Hyperkinetic Reaction of Childhood in 1968. And then later on in 2000, they came up with the 3 different subtypes. And then in 2013, what's of great note is that FDA approves the Theta-beta ratio as a recognized diagnostic assessment. So that was huge for our field. On the next slide, I show the 3 subtypes. We have the inattentive, hyperactive, and combined. And then I also wanted to mention an honorable mention of ADHD. It's not in the DSM-5, but it is a term that is trending on Instagram and TikTok to say those who have autism as well as ADHD kind of call themselves ADHD. So it'll be interesting to see what the future has um, for autism and ADHD. On to our next slide. Um, we'll review the EEG, AI, and QEEG. So while the DSM gives us good behavioral diagnosis, it doesn't tell us about the underlying neurobiology. But first, in order to have um, a look at the neurobiology, we need to collect an EEG scan. So on the next slide, for our beginners out there, this just shows uh, on the next slide. This just shows what the EEG is and how we get clean signals. We want brainwaves in, brainwaves out, not garbage in, garbage out. On the next slide is just a brief review of what our brainwaves are, from delta, the slowest, to high beta. And then on the other slide, once we collect our EEG, we want to make sure it is void of artifact. So here is kind of a standard process for filtering out noise and artifact. We also, for iMedisync, use Amica, which is AI automatically selects different noise components. Then on the next slide, something specific to iMedisync software is we have independent component analysis, which is able to use CNN, which means convolutional neural network. That is AI deep learning to recognize shapes and patterns. So we can see in the diaphragm that we're able to classify different signals as neurological signals, as muscle, as horizontal or vertical eye movement. And then on the next slide, if you just hit it twice, we have eye blinking and horizontal eye movement. So these EEGs were collected with the iSync Wave, our dry EEG device. It took about 5 minutes to prep the client and get a good signal. And then through our software, we're able to remove the eye blinks and the horizontal eye movement. Go ahead and click twice for the next one. So here we show, again, eye blinking and temporal muscle. And then below shows the filtered out signal. And on to the next. Again, strong temporal muscle at T3 and T4, right above where jaw tension is, and how we're able to clean the signal for this. And then one more. There's an example of cardioballistic, where it kind of bounces. And then the last one is our another example of auto denoising. All right. So before the experts out there tell me that they like to edit their own EEG, which is amazing. You still can do that with our AI platform. You can choose to accept or reject what AI has deemed as artifact, and you can challenge it. So here we have component 1 in ICA. There's 19 components based on power. And so component 1, we can see that it's localized on the forehead in red, and that the power spectrum shows it's about 1300 hertz. So we can say, yes, AI, I agree. Please continue to reject this. And also, you have our timestamp selection. So whether you're a beginner or an expert, you can control what level you want to edit the EEG signal. All right. Now that we have a clean EEG, we run it through our software. So iSync Brain's QEEG normative database was built by collecting the world's largest number of healthy people's EEG data. It took Seoul National University 8 years to complete this collection. There's about 1,800 brains that were scanned and collected. 508 were removed for various reasons that they didn't meet the healthy criteria. And then we have a remainder of about 1,300. And it is the world's largest. It's also a standard out there for databases because it distinguishes between gender, male and female, as well as age. All right. So once it's processed through our cloud software, we process it through the cloud so you get your results back within 5 to 10 minutes instead of a day or two. It's really instant and convenient. We get our QEEG, and it just takes a computerized process that makes these recordings into a digital equivalence. So we can look for further patterns to recognize ADHD, as seen here with theta and alpha at the bottom top of map. We also have a 3D rendering of it and our connectivity reports. All right, so now let's move on and get into the nitty gritty of ADHD phenotypes and what those are. Next slide. Okay, so this comes straight from Jay Gunkelman. He and his colleagues did research and they discovered 11 phenotypes in the EEG. Of those 11, these four are related to ADHD findings. So we have epileptic form, which is our spike and wave, diffuse slow activity, which can be delta, theta, and even alpha, and our frontal lobe hyperperfusion disturbances. This could be like our theta-beta ratio. The lowest age in soul that was a question in the chat. If we look at it, it's age 4 all the way up to 82 years old in the database. So frontal lobe hyperperfusion disturbances and spindling excessivity.
Text him.
All right. So
I sat over here between 9 and 9:30.
all right. Next one that we had is if you go to the next slide. I made this new graph because in the literature, there's a lot of talk that isn't divided into those 4 categories of frontal lobe, diffuse slow, excess beta, and epileptic form. So I created other categories. In the literature, you'll hear a lot about high theta-beta ratio, alpha asymmetry, alpha dysregulation, excess delta, and beta. So those are kind of what we'll be reviewing today. These phenotypes are kind of compared to ADHD being like a headache. The symptom is the same, but it could be because of dehydration, stress, or a tumor. So we have these phenotypes to let us know what kind of ADHD it is. Is it high theta-beta ratio? Is it excess alpha? They all have the same symptom of ADHD. All right, next slide. So here we have our EEG power spectrum that represents 4 different types of ADHD. The first pattern shows excessive alpha wave in the frontal lobe. This is our gray peak right there, and its frequency is that of a normal person. However, the yellow pattern is excessive alpha wave in the frontal lobe, but it's slowing down. And then our blue one is a theta peak, and our green one is excessive beta. All 4 of these are different signatures in the brain, but they are related to ADHD. All right, next slide. So excessive theta, or also theta-beta ratio, is there's a 3 to 5 theta to every 1 beta, as researched by Joel Lubar in 1999. Martine Arns came out with a study in 2013 saying that the ratio of 4.5 to 1 is actually a better threshold to distinguish ADHD. So that means you have more theta than you do beta in the brain. All right? You don't have to worry about that. Okay, so here is just a 3D viewing of what someone with excess theta in their frontal lobe looks like. We have the ADHD there, and as well as the connectivity. This is in the anterior high theta-beta ratio. So this is our most famous phenotype. Is often called our classical ADHD signature. So if I were to ask you to think of someone you know who has ADHD, chances are the person you think of, this is a type of ADHD they have. This is also the most researched. So it's what we know the most about through our research. This is kind of like the daydreamer head. They're also very artistic and creative, hence the song we tried to play earlier. This brain is under aroused, and it's why stimulants help tremendously. It increases beta while decreasing theta. And it literally wakes up their brain. You'll see some people will naturally try to have a natural stimulant to wake up their brain. So that's where the hyperactivity comes into. They're naturally trying to wake up their brain through motion. You might ask, why do you give a stimulant to someone who's hyper? Well, the stimulant wakes up their brain so they can calm down. Also, if someone's concentrating, their eyes might flicker back and forth because their eyes are movement is trying to stimulate the brain. So the stimulant kind of replaces that. Physically, here we are looking at frontal lobe hyperperfusion. This is where the frontal lobe lacks adequate blood flow or glucose. The neurons simply can't maintain a fast activity, and so they downshift to excess theta. My husband has this, and he will call, I need a dopamine dump. That is kind of like his code word for I gotta get my brain active so I can perform a more challenging task. So he'll go to the gas station, he'll buy a donut, he'll get his caffeine stimulant, and then he'll blast music to kind of wake up his brain so he can focus. The stimulants also help increase the frontal blood flow, effectively waking the prefrontal cortex. And next, I just have a slide showing an example in the raw EEG, what theta in the front of the head looks like. And then on to the next slide, we can have another EEG view of theta at the midline. And then the next slide shows a topo map of how this theta looks like in the brain. So you can see here at the 4 to 8 hertz, which is a frequency of theta, we have the red in the frontal lobe. We also have some slowing of alpha. And then go to the next slide, and this one you'll want to hit play for. Oh, I did not give you access. I'm sorry. So this slide is just beautiful 3D brain scans where they're rotating so you can get the view, and then they split and divide. And then you can see very clearly that the red portion shows that excess theta. All right, on to the next slide. So now we're going to talk about a different brainwave, alpha. So it is slower than theta. And on to the next slide, we have in this topo map, you can see that delta, theta, and alpha are all have a standard deviation away from the norm. So this is one where they have excess delta, theta, as well as alpha. And if you go on to the next, this phenotype we're talking about involves alpha dysregulation. Alpha is our idling rhythm, normally seen in the back of the brain when we close our eyes, because when we have a lack of stimuli, visual input, the alpha goes up in the back of our head. In this phenotype, we see it appearing in the frontal lobes while the patient's eyes are open. This represents a brain that is disengaged. It's not as deep of a sleep as theta, but it's like a mental screensaver, and the patient is a little more mentally checked out. If we pay special attention to alpha asymmetry, this is where one hemisphere has significantly more alpha power than the other. So if there's more alpha in the left frontal lobe than in the right, it correlates with depression or withdrawal. And this is where the patient feels emotionally overwhelmed, maybe socially detached. And this can explain why some ADHD patients struggle with the comorbidity of mood regulation alongside with the inattention. So for someone who has alpha asymmetry or dysregulation, SSRI or SNRIs are more preferred medical use. All right, on to our next one. And this is just the raw signal that shows that slowed alpha in the front of the frontal lobe. All right, next slide. So it's worth mentioning that frontal alpha can co-occur in OCD, anxiety, early dementia, depression, and ADD. So it's important that you also do your intake and figure out the medical history of the client. And then the last one that we have is our excessive spindling beta. This is a paroxysmal phenotype characterized by a sudden high voltage burst of beta activity. And you can go to the next slide. So as you see here where the EEG gets darker, this is that sudden burst high voltage of beta. It's unlike a steady hyperarousal, this reflects a transient loss of cortical control, and it manifests clinically as impulsive outbursts or sudden irritability. In contrast to the sleepy alpha brain, excessive beta phenotype is hyperaroused. Beta is a fast frequency used for active processing. So when there's excess beta, it's very noisy across the whole brain, and the patient gets stuck in overdrive. They can't filter out stimuli because their brain's already maxed out. It's kind of like a busy brain. These people react poorly to stimulants due to their brain already being at high speed, and stimulants could cause jitters. So unlike my husband who needs a stimulant to wake up and speed up his brain, I am a beta head. And so when my husband blasts loud music to get his excess beta more stimulated, I'm like, please turn the noise off because I'm already overstimulated. All right. Next slide will show us a topo map of what spindling excessive beta looks like. And you can see they have both beta 2 and beta 3 in their head, as indicated by the red and the yellow. And then the next one I have is a power spectrum showing. This is really neat. iMedisync has the ability to take 2 EEG scans and overlay them on top of each other. So the red marking here is someone's beta brain, and then the blue line represents them after medication. So if you look at F7 and F8, where the red is peaking, after medication, you can see that beta peak has gone down, and showing that it has improved their brain signature. So the last one we're going to talk about before we dive into our case studies is epileptic. And the next slide shows us the raw of what this looks like. There's spiky waves. Usually they don't come from just one channel, but appear simultaneously in neighboring channels with field and phase effects. Interestingly enough, is you can have an epileptic spike and wave and not realize it. I had a case in our clinic where we had person we mentored with Jake Unkelman, and he was able to find a very small spike and wave, is barely noticeable on the recording, and it only occurred once in the 10-minute recording. And Jay pointed it out to me, and the client then went and spoke with their doctor. They got on anticonvulsants, and that was able to help them with their medication. Now, if you were to give someone a stimulant with this, it would add arousal, and that can lower the seizure threshold and even cause a seizure. So again, it's important to look at the EEG to know what type of medication to prescribe. And then the next slide is just another raw EEG showing the spike and wave a little more pronounced. And then our final slide is this beautiful pie chart that kind of divides everything we've talked about in a beautiful picture. So we know there's multiple EEG phenotypes, as we just reviewed. So we have the blue piece of the pie is the frontal theta, which is really good for stimulant responders. The orange is our frontal alpha, which is good for SSRIs, SNRI. And then that light blue piece is divided between for our overaroused, the beta spindles in gray, which is ion channel blockers. And then the epileptic discharges is the anticonvulsant responders. So based on what the brain tells you, what kind of headache they have, you can know what they'll respond better to. In the next slide, I'm just putting it up there for your reference. I'm not going to go into it too much. We do have iMedisync Americas has a YouTube channel where Jay Gunkelman and Dr. Karush presented specifically on medication for ADHD. So if you'd like to dive more into the medication side, please check out that YouTube video. And the bottom here, I like to stand out that sometimes you can have more than one phenotype represented, and you can have a mix of fast and slow brainwaves. And that could be you pair them with a stimulant and an anticonvulsant, or like my son, he's on a stimulant and guanfacine to help with him. All right, so now we are going to dive into some of our reports. So this slide here is this is an iMedisync exclusive report. It shows our theta-beta ratio. Now, if you ever see TBR, that's what that means, theta-beta ratio, and then there's theta-beta 1 and theta-beta 2, TBR2. So this shows us that AI has deemed that the theta to beta ratio is great, and this is during resting conditions. The clinical significance of this is the increased theta-beta ratio is associated with increased reward responsiveness, risk-taking, and impulsiveness, and it tends to reflect attentional cortical functioning and behavior inhibition. So this is a majority of the children we see are characterized as this. That's the most common type of ADHD is the theta-beta ratio. All right, then our next slide we have here is also an EEG summary report. It is my favorite because it gives us a good snapshot of what's going on in the brain. So here we see the underactivity, which is actually in red, and the blue is hyperactive. We get that visual description. This is based on the theta to beta ratio at source level. It compares the gender to age specific norms and then color codes it. On the number 2, brain activity analysis, it divides each of those into the frontal, temporal, parietal, and occipital lobe. So the left hemisphere we see is 15 percentile and 4.7 percentile. This is based off of anything under 17% is a standard deviation away from the norm. Anything over 84% would be considered hyperactive. All right. So on this report that we have, the x-axis is the z-score of theta power, and the vertical axis is the z-score of beta power. And so we can see each of those polka dots on the screen represent the frontal lobe left or right. And as we can see, these two down here are blue and orange, which is our frontal left and our temporal left. They score as underactive. All right. So this is our EEG summary. All of the people that I review it with tend to say it's kind of like the crystal ball of the brain. They'll say, "How did you know that about me?" And I said, "The report measured your brain signals and came out with this." So this is based off of 68 subregions defined by the DK Atlas. DK Atlas is used for MRI imaging. This report shows the source level theta-beta ratio of each region as a percentile compared to our normative distribution. So there's 13 regions in the frontal lobe, 10 for the temporal, 10 parietal, 6 occipital, and 4 occipital subregions. And what I love about this is if you have a client in your office and they don't know anything about the brain, they don't even know what a frontal lobe is, it explains it in detail. It has pictures. Like here we're looking at the frontal pole. And so here is in this dark blue region, we have the frontal pole, and it gives the key functions about, monitoring, evaluating outcomes, sustaining, transitioning attention. And then if they score low, which they did, they're under 15, 17% here, that they have difficulties in planning and making decisions, a tendency to repeat similar mistakes. All right, next slide. This is just further different regions of interest and their score. You can see they did a little bit better with the superior frontal, so maybe they have less difficulties with memory and spatial processing. All right, on to the next report. So this report is one of our pediatrics. This for those 20 years and younger. It's the EEG summary, additional to the EEG summary. And it uses theta-beta ratio at CZ and is with eyes open data. So we can kind of see where they're at. The green is their confidence interval. So they're kind of on the higher side of the green, still within the norm. And then the last I have 2 more reports I want to review. This next one is the age brain development. Russell Berkeley talked about how those with ADHD are usually like 1/3 their age because of their brain development. And so this is a nice picture that shows the brain relative to the age of the actual measure based off of the 8 regions of the brain. And the trend of decreasing delta and theta and increasing alpha and beta over the course of the pediatric development is how they derive this number. So here we see the current age of this person is 7 years, but their brain is actually very well. It's 9 years. Usually I see the opposite where they're 12 years, but their different regions of their brain might be 8 years. And then the last report I wanted to review with you is our connectivity report. This shows that the right side of the brain is processing information at a hypocoherence, and as well as their connectivity. All right. On to the next slide, we're going to discuss some photobiomodulation. So photobiomodulation is photo meaning light, bio meaning life, modulation meaning change. So we're using light to change biomolecular level. The definition is it uses a low-level laser or near-infrared light to stimulate cellular function and promote healing. iMedisync uses near-infrared at 850 nanometers. The mechanism is the light is absorbed by the cells, promoting cellular repair and reducing inflammation. So this next slide, we can see that how our device administers the PBM is through each of the channels. There's an LED light that it is fixed on a pulsating rate based on the speed and frequency of the brain you're trying to imitate. And here we have our beautiful pie chart again, where it shows for those with the slower waves, we have our frontal theta in blue, our frontal alpha in orange. Those we want to improve beta frontally. So we'll use more of a beta frequency with PBM, and it'll pulsate at that rate. And then that light blue chunk, which is our overaroused part, which is 24% of the ADHD population in this study, we want to use more of a globalized SMR frequency or an alpha theta or even a 1 Hz inhibition protocol. And this is to kind of slow down that overaroused part of the brain. All right, on to our case studies. So if you go up one more slide or back. All right, so this is 11-year-old Mel. It's a preteen who was expelled from school for frequent use of violence with his friends. He'd always get into fights, and it led to his expulsion. His EEG is full of very slow theta, which decreased over the course of his care. So in the first phase, if we look at the fourth circle in, that's the 4 hertz, the theta was reduced on the second image in the middle there. You can see how that theta was able to be resolved. And then in the next phase, the 6 hertz frontal theta was also reduced. And you can kind of see the progression. This was 3 sessions a week over 3 months. And we have the baseline, a mid-assessment, and the post-assessment. So what was done in the previous, in the following slide there, is we did a stepwise optimization protocol. So this child was very sensitive to PBM, so we just started off slowly. We did 10 minutes at 13 hertz for the whole brain, and then later we added 40 hertz to that. So it was 10 minutes, 13 hertz, and we stacked it, the protocol. So one right after the other, 10 minutes, 13, 5 minutes, 40. And then we were able to add in some SMR. We chose 15 hertz because his brain was faster to begin with. And then in the third optimization, we're able to separate the occipital and frontal frequencies into 10 hertz and 15 hertz, and then finally added 14 hertz to them. Oh, we're not on the correct slide. Go back. Oh, no, back 2. Forward 1. Wait, sorry, back 2. It has there we go. Perfect. So we started off with 13 hertz at 10 minutes and then added an additional 40 hertz to that. Then we selected HMR or SMR protocol where it's 13 to 15 hertz. And we decided to go with 13 hertz because it was much slower in the third optimization. So this was kind of the protocol for the course of those 3 months. And then the next slide shows, again, the before and the after for the intervention. And we can see that our 4 to 7 hertz cleared up drastically. All right, so now we have another case example to review in the next slide. So you can see that 5 hertz and 6 hertz are those blaring red headlights staring at us. This is of a 27-year-old with autism, ADHD, an intellectual disability, OCD, and epilepsy. So quite the mouthful. Loss of impulsive behavior, lack of self-control, and aggression. They were verbal but not advanced. This baseline shows very slow 5 and 6 hertz. So in the next picture, a protocol was designed to do 13 hertz globally for 15 minutes. And this was done twice a week for 6 months. At the same time, their doctor prescribed them Concerta, which is added to their existing medication. And then they also did transcranial direct current stimulation for the prefrontal left and right lobes. Okay, and then the next slide shows us the before and after. And so we see those headlights have now shifted. Instead of being 5 and 6 hertz, they're 5. The 5 has cleared up, and then we have 6 and 7 with just a little bit in the left frontal. We did train at a frequency of 13 hertz, so it does show that the 13 hertz was induced by PBM has increased. And then the next slide is another view of the same client here. So in addition to normalizing the EEG after 6 months of treatment, the behavior changes were quite remarkable. He became more stable. His impulsive and aggressive behavior was significantly reduced, and he even became more verbal than before. So this figure shows us the spectrums of the EEG superimposed on top of one another of the improvement. So the red is the prior to the interventions and the blue is after. And you can see that the power spectrum has gone down there. All right, so now I'm just having a few raw EEG examples to show you. So this is the following slide. Okay, so this is an example of a PBM protocol that we applied for someone with frontal theta. And the persistent theta in the frontal lobe is characterized by a lack of dopamine. This can be stimulated with beta frequencies up to 2 rows or 3 rows to stimulate. So in general, adults are thought of having 2 rows of the frontal lobe, while children and adolescents have up to 3. This is based on developmentally. The first and second rows eventually differentiate into the frontal lobe by adulthood, while the third row differentiates as a sensory motor area. So depending on the age can depend on if you do the 3 lobes or the 2 rows. All right, the next slide here we have an example of beta spindling. So this one we did a 1 Hertz inhibition to stabilize, also with SMR. They were conjoined 5 minutes with SMR, 10 minutes with the inhibiting 1 Hertz. And this helped optimize it based on the individual's EEG. All right. Next one, we have an example of our Epileptiforms with the spike in wave. So this one we used a 1 Hertz inhibition globally with SMR again to optimize the client. And that is what I have for you today. Thank you so much. Here's my contact information if you would like any additional information like the slides or sample reports, please reach out to me. And then lastly, I just want to do another plug-in for our workshop. It will be in Denver on June 12th to the 14th. Very much clinical application, so you can be more confident in office with your clients. I hope I can see you there. Yeah, of course.
Thanks so much. I'm actually going to take over for Jeff a little bit. His internet's down. So I was just going to go through some of the questions that were in the chat and see what we can get to. The first was actually a question about the database and what the age range is. And maybe if you could tell us a little bit about the Korean database.
Yeah, so we actually have a publication on our database since it is the world's largest. And the age ranges were 4 years to 84. And I'm trying to pull up this picture on the slide on my side. So they went through a process of editing what is a healthy population. And so we started off with 1797, almost 1800. There's no history of neurological or psychiatric disorders. And then that moved into more of a behavioral assessment, a neuropsychological evaluation with emotional and behavior assessment. We lost 508 due to that assessment. And so our healthy norm became close to 1,300.
Okay. Sorry, go ahead.
And I can send out that publication that goes into the inclusion and exclusion criteria in depth.
Another person had a question about sleep deprivation versus ADHD. Wrote that Dr. Matthew Walker, author of Why We Sleep, has determined by big data analysis that are 50% of those diagnosed with ADHD are actually sleep deprived. And I think those of us who work with people who have ADHD would agree with that, at least 50%. And is there a way to distinguish between sleep deprivation versus ADHD, particularly if you're thinking about prescribing stimulants?
Yeah, so, I mean, you can look in the EEG for the different stages of sleep. Um, I know, like, we had one recently where they had just so much data, and, interestingly enough, they were prescribed a stimulant, which kinda made it worse, but while their eyes were open, you could see them falling into the first stage of sleep. And I also know this to, be a very insightful thing where the future should look more on sleep deprivation for ADHD. So, for instance, personally, my son had a tonsillectomy, that improved his behavior drastically. And now we're noticing his behavior isn't as good. And so we took him to the ear, nose, and throat, and he has a deviated septum. No, deviated, what's it called? The part of his nose passage isn't opened as well. And so, he's only 8. They don't do surgery till he's 10, but we're kind of in this limbo of like, we need to improve his sleep to improve his behavior. However, on the EEG, it also very much shows that his dad has it, his mom has it. Genetics also played a part. So I think in some cases you could have both, but in other cases, improving sleep would definitely help with ADHD symptoms.
Right. There's also a question about whether there's correlation between sort of the typical diagnostic approach and your method, which I think we need to remind everyone, QEEG is not diagnostic. But what you're finding, at least, to how it correlates with sort of more standard diagnostic approaches.
Yeah, so thank you. You took the words right from me. We always have to say this is for screening purposes. The clinician is the one who makes the diagnosis. Um, I think what's really important here is that going back to the phenotypes, how there's different phenotypes to help you assess what the diagnosis is and even what medication to use. And I think this question was asked when I was reviewing some of our iMedisync reports. And so again, these are considered screening reports. They are mostly based on the theta to beta ratio right now. And so that's also something to keep in mind, that maybe if they're a beta head, that won't show up in the theta to beta ratio.
There's also a question, actually, I appreciate this next one, is whether there's a different headset for children. I was part of the FDA study, so I used the first version, and it was heavy. So I'm curious about that as well, whether it's lighter for children.
No, that's great. And thanks for being a part of that FDA clearance. So I actually have it right here. This is the lighter, which you can't see. This is the lighter version. Um, and That's what we came up with to accommodate for younger ages. You can still be an adult and use our iSync Me is what it's called. And um, that makes it a lot easier for kids and the kid size of their head.
There's also a question about, um, tell me again how you know what locations and frequencies to train, and how do you know that they're the correct ones?
What locations and frequencies to train?
When you design a protocol, I think.
Okay, is this for PBM then? So,
Keep it generic for
right.
anything.
So, looking at the EEG, you can kind of see, where is the excess slowing or the beta spindles. So I really like that pie chart that shows us if they have a slower speed like theta, frontal alpha, you're trying to speed up the slow. So you'll use more of a beta frequency to speed up the slow. Where if you're doing beta, you do not want to train it fast because they're already over aroused. So that's where we look at SMR. It's kind of a standard. I find that protocol for PBM is a lot easier than protocol for neurofeedback. And so if I I'm a beta head, so I actually did a SMR training, and I had to do it in smaller doses. I couldn't go 10 minutes because I'd get irritable. My brain didn't like doing something different. So I had to shorten it down to 5 minutes instead of 10 minutes, and that was using SMR or the 1 hertz inhibition.
Okay. Well, I think that was the last question in the chat. Rebecca, thank you so much. And I think the recording for this will be available not in the not too distant future.
Yes. And Camara said anoid. It's the deviated anoid for the sleep issue. But thanks so much, everyone, and thank you for having me. I really appreciate NRBS and all the wonderful things you guys are doing.